Hello, and welcome to the Hawaii Book and Music Festival, the wellness track. We're beginning a 1-hour panel on long COVID. You know, we've been through surges, we've been through questions, we've been through waiting for vaccinations with COVID-19. Just 30 to 40 days ago, the state was at a peak of cases. We were concerned that the hospitals would be completely overwhelmed or on the verge of being overwhelmed. And now the last 3 to 4, 5 weeks, we're seeing descending numbers. It looks like the worst is behind us on this surge. And there are calls for lifting mandates, returning to life as normal, getting our lives back, getting our holidays back. But there's one piece of the COVID pandemic that persists, and we read about it, we hear about it from time to time in Google or in the papers. But long COVID, this idea of not just getting COVID and getting better, not just getting COVID and passing away, but getting COVID, getting over it, but still having pain, discomfort, shortness of breath, disability, organ problems for a long, sometimes a very long time. That's the topic of this panel. I'd like to introduce some notable experts who will be discussing their role, their research, and the recommendations on long COVID. First, we have Dr. Bennett Loui. He's a primary care provider at Straub Medical Center, born in Honolulu and studied at Brown University in Thomas Jefferson. He did Chief Residency at University of Hawai'i, and he's currently the Chief of Internal Medicine at HPHMG, and he directs the long COVID care program at Hawaii Pacific Health. Dr. Loui, welcome. We also have with us Dr. Natasha Ching, and Dr. Ching is Assistant Professor of Pediatrics at the John A. Burns School of Medicine at UH, and she's also a pediatric infectious disease specialist at HPHMG, working at Kapilani Center. She's been involved with COVID-19 on the treatment of pediatrics and has developed diagnostic and treatment protocols. Welcome, Dr. Ching. And Dr. Neil Palafox, good to see you again, is MD, MPH, Master's in Public Health, currently Professor of Family Medicine and Community Health at the University of Hawai'i. He's a member of a 4-state COVID-19 response team and has been University of Hawaii West Oahu COVID-19 contact in the contact tracer program. Welcome, Dr. Palafox. So we are going to have each of our panelists speak for a few minutes, and there'll be an opportunity for questions and dialogue to follow. I think find this to be an interesting panel. Thank you for tuning in. Dr. Loui?
Hi, thanks, Ira. I really appreciate the invitation to be here, and thank you for those who are watching. This is a really important topic to me. Introducing myself, as Dr. Zunin mentioned, I grew up here in Hawaii and was away for school for a number of years, but it's really great to be back practicing in Hawaii and serving the community that I grew up in. I've been at Straub for a number of years now, and I've had the honor of being involved with the long COVID program for Hawaii Pacific Health. We've been enrolling patients since the end of 2020, and I wanted to share some information about long COVID in adults and a bit about our program. So thank you. I'm going to start sharing slides now, and let me see here. Okay, so I think I'm up. So Long COVID. So there are a lot of names for this condition as we are learning about COVID and the long-term effects. You might have heard long hauler syndrome, post-acute COVID-19, and some other terms. And we're starting to define this better with the WHO and CDC settling on a condition that is associated with a spectrum of physical, social, and psychological consequences. And we start really considering it long COVID at least 4 weeks after the onset of symptoms. It's looking more like we would really consider after 2 months to 3 months as of the most recent consensus with the WHO. Long COVID can happen in people who are severely ill, or even if illness initially was mild. And there are some great effects on the individual as well as the entire community because of this long COVID problem. How common is this? Well, it depends on which study you cite, but there are initially reports were coming from all over the world on different populations and with different levels of looking at different types of conditions, because we didn't even have a definition for what long COVID involved. But out of Europe, Asia, and US, some of the numbers that you might see are long COVID being present in 10 to 13% of all comers who have had diagnosis of COVID. And after 8 weeks, 5% are still reporting conditions. The hospitalized population is more ill, and a third have been reporting or long COVID after a month. There was a study in China that hospitalized patients that after 6 months, most people still had some symptoms. Even after asymptomatic infections, a population study noticed that about 19% of these patients sought treatment for COVID-like conditions. So the numbers are out there, and if you do the math out of the millions of people in the world that have had COVID, you can imagine how many millions have long COVID, and in Hawaii, there must be thousands. What puts you at risk for having long COVID? Severe illness, as I mentioned, being in the ICU on a ventilator does increase your chance of having long-term symptoms. We've also noticed higher rates of this in the obese, heavy people. Older age is associated, and women tend to have more long COVID incidents than men. History of illness, especially chronic conditions, especially respiratory disease and anxiety and depression, are also frequently associated with long COVID. What is happening with this? And there are a lot of theories. It's probably a combination of different mechanisms that cause long COVID, including just recovering from severe illness in post-intensive care syndrome, inflammation, blood vessel injury, immune system problems that follow this severe viral illness, or even the persistence of the virus in the body that's been sequestered away and comes out over a long period of time. So there are a lot of theories that are being tested out right now, and there probably is more than one explanation for the syndrome or the condition. I'm not going to go into great detail over all of the different things can happen. What I want to communicate is that this really can affect all aspects of life and health, including general fatigue. There is a severe type of post-exertional malaise that many people who have had COVID report. Just going out to the grocery store can put them out for days. And even athletics people who have a really high level of capacity before illness can become very ill, very fatigued for a long period of time. Brain fog is a very commonly reported symptom. Headaches, cough, and difficult breathing, very common. Chest pain and palpitations. Anxiety, quite a few people have hair loss and persistent loss of smell, and it goes on and on. But something that is really something we need to recognize is that these persistent symptoms can really impair a person's ability to get back to their normal lives, get back to work, get back to engaging with family. And so it's important that we recognize this, and in those that we know that have had COVID, we should be sensitive to this, this being a problem. Here locally, and well, around, in all communities, there's been a focus on trying to take care of people with long COVID. Here in Hawaii, the bigger programs are the Queens Post-COVID Recovery Care and Care Clinic. It's based at Queens Punch Bowl, and this involves in-person evaluation. It's a really nice comprehensive evaluation, and and so that is open to referrals from all around. The Hawaii Pacific Health, which is the clinic I direct, is a virtual clinic in which we have providers contact and follow patients with long COVID over time by video or telephone. And it's important that we coordinate with the primary care doctor. So we take referrals only from the PCP. And I'll tell you a little bit more about what we're seeing. For long COVID, we like to know that there was a documented positive COVID test. Some people will come in with symptoms and think they have long COVID, but they actually never had COVID. So we have to kind of sort that out. There's an antibody test out there if there's uncertainty, and sometimes if we find a positive antibody test, that would make it clear that this person did have COVID-19. And of course, we are looking at people who have had symptoms for at least 4 weeks or longer. This is a little word cloud that I just took the referral requests out of our system over a period of the first 6 months and put it in this word cloud. So these are literally the words that were typed in when patients were referred to the long COVID program. You can see brain fog is probably one of the biggest ones. Pain, fatigue, difficulty with cough, breathing, and oxygen. But it goes all the way down to the hair loss and other problems. So we're seeing quite a variety of different reasons for referral, and usually a combination. Looking at the patients, we've had about over 100 patients come through our program. Some are still following, some have passed through. What I find interesting is that if we break down the patients we've seen, the age range is kind of evenly spread in through the deciles of life, and people in their 20s, 30s, 40s, maybe a little bit more in their 50s and 60s. On the lower part of the graph, you'll see this is at the same time the incidence of COVID by age, and more younger people are diagnosed with COVID than what we're seeing referred into us. So this goes along with the understanding that older patients have a higher incidence of COVID-19 or long COVID. So we're seeing older patients in general come in, but across all age groups, men and women. You see in the state, more men are being diagnosed with COVID-19, but in our long COVID clinic, our referrals are 60-40 women being referred in. So we're seeing a little more women than men in the long COVID clinic. So how do we treat this, or how do we approach this? And there are various emerging guidelines and knowledge. Research is very active. The NIH has a huge over $1 billion research offering right now to learn more about this. And our approach is that in the first 3 months of long COVID, diagnostic tests are actually not usually very revealing. They're often very normal, or CT scans of the brain, chest X-rays, EKGs don't always show things. In fact, they rarely correlate with the symptoms. So we're conservative with doing a lot of diagnostic tests in the first 12 weeks. What patients all need is reassurance and validation that this is a real thing, and we can support them through it. We want to set goals, functional goals, achievable goals, to make progress, and guidance will change. Only thing constant is change. So in our management, as I mentioned, conservative approach, discuss vaccinations. People with COVID are at increased risk for illness, so getting vaccinated for pneumonia, flu, and COVID-19, of course, are important. And we also help with referrals to specialists and other areas like physical therapy, which are really commonly needed. So this is my last slide. So how do we not get long COVID? Well, obviously not getting COVID-19 in the first place will eliminate the chance of getting long COVID. There was a report about people who have been vaccinated have half the risk of getting long COVID compared to people who got COVID and were not vaccinated. So even if you get COVID, if you've been vaccinated, you're less likely to get long COVID. And people who have long COVID symptoms seem to have some improvement in symptoms. A lot of, at least anecdotally, in an internet poll, that there's a lot of symptoms actually improved after being vaccinated. And there are studies going on at Yale and other places to really understand if this is true and why it's happening. Is it resetting your immune system with a vaccine? We need to learn more. So research is ongoing, and we expect to see ongoing need for long COVID care for many months and years to come. All right, thank you.
Dr. Loui, thank you so much. You're tuned into the Hawaii Book and Music Festival, the wellness track, and this is a panel on long COVID. What's that? That's when you get COVID-19 and you still have symptoms. So often we think that we get it and it might be so bad that we go to the ICU and pass away, but otherwise we just recover. Long COVID is when the symptoms persist, and there can be a lot of different symptoms. Dr. Bennett Loui just presented. He's Chief of Internal Medicine at Hawaii Pacific Health Medical Group and heads up the long COVID clinic at HPH. One of the last things he said, very interesting, that being vaccinated can, and even having a breakthrough case, really dramatically lowers the odds of ending up with long COVID. Our next speaker is Dr. Natasha Ching. She's a pediatrician on faculty at the John A. Burns School of Medicine, a professor, and also works at Kapiolani Center for Women and Children, focused on pediatrics, infectious disease. Has been very active in studying and treating, managing long COVID. Dr. Ching?
Thank you so much, Ira and Roger, for this opportunity. Let me share my slides. And I just wanted to say, just as Dr. Loui talked about coming home, I was a JABSOM grad, and I went away to New York Hospital Cornell for my pediatric residency. I went to UCLA for my pediatric ID fellowship, and I spent time at UCLA on the faculty there. I then transitioned to a clinical ID job in Austin at Dell Children's Medical Center. And in 2014, I was able to come home to Hawaii to practice pediatric infectious disease at Kapiolani Medical Center for Women and Children. So I'm happy to be home as well, as part of Hawaii. And as you said, I've been working on the pediatric end of infectious disease and COVID-19. So I'll go ahead and start right now. I just want to frame the talk about the numbers. In the US, as of last week, Thursday, there are over 6 million total COVID cases reported for children. And children are representing 16.4% of all cases. And in terms of hospitalization, it can range between 0.1 to 2% of all cases being hospitalized for severe disease. But looking at the change, cumulatively, there's been over 130,000 cases in the past week, and that was representing about 25%. So 1/4 of all the cases in children. So the theme is, many of these children may be unvaccinated. And as we've heard, the surges that we've seen in Delta is the disease of unvaccinated. And overall, it's about 5% of cases in children from the beginning. And what's been going on in Hawaii? Well, I look back and these are random dates, but usually they're related to a talk that I've been giving or reviewing the data for our cases. But basically, a year ago, children made up about 7.8%. In May of this year, it's about almost 13. And really here, September and October, we're at 18%. So we actually are above the nation. This graph shows all of the states representing the percentage of children. And you can see here, Hawaii is at 18%, so we're over that 16%. And cumulatively, our cases are 4,838. So if you look at the cumulative per cases, we're good. We're lower on another slide that I'm not showing here. We're lower than the majority of other states. But if you think about our population of children, we're nearly 300,000 children under the age of 17. And the number that we're looking at, hopefully coming up soon, is really the children are almost 200,007 for ages 0 to 11 years. And that's a large chunk of our population in our state. Here again is some of the same data in terms of 18%, but looking at the whole pandemic, the top graph over here on the upper left-hand corner shows this. If you just adjust your eyes to the second highest gray dot, that's the children from 0 to 17. So we're above that state weekly new cases averaged out on that orange. And here on the bottom, you see that number with the 0 to 17. So, here we are in October of 2021, moving forward. And so what's been going on with pediatric patients? Well, initially, I know I had to speak in March of 2020 when we had no data except for what was out in China. And, in the beginning, the initial reports are children, teenagers had mild or no symptoms. But as this whole pandemic has been evolving with multiple new data every day or every week, we have seen many different situations where children can have severe disease, needing hospitalizations if they have certain conditions, just as adults needing to have oxygen, respiratory support, eventually, possibly even a ventilator. But children now also have multiple episodes where they've been reported with long COVID, with really many similar situations and symptoms that Dr. Loui has mentioned. So I won't go into it. But basically in the UK, they've shown about 52% of teens and young adults that have had lingering symptoms. And specifically, children were reported to have symptoms 5 weeks after infection, and the range is between 13 and 14% in children between 2 and 11 and 12 and 16. It's an international tour of who's reported what. But basically, one of the early reports were 5 children, a small case report in Sweden, where patients had long COVID and really were unable to go to school, really had difficulty eating and daily living activities. An Italian study looked back and saw almost 43% of the patients had one symptom present 2 months after an acute COVID infection. Israel reported following patients prospectively in a pediatric multidisciplinary clinic, and they found that 60% of the patients had some persistent symptoms with a large range between 1 and 7 months. And the top 4 symptoms they talked about was fatigue, dyspnea, body aches, sleep disturbances, and as well as the multiple list that has been seen previously. And I think the other part to bring home is that many of these long COVID cases were noted to be after mild disease or even no disease, the asymptomatic disease. And that's important to think about. If we say the majority of children may have mild or no symptoms, this still is a potential possibility for pediatric patients to be considered for long COVID. But the second part of long COVID is a little bit different, and what I wanted to talk about was the multi-system inflammatory syndrome in children associated with COVID-19, or MISC or MIS-C. And this is a rare complication that can happen 2 to 4 weeks, even up to 6 weeks after an acute COVID infection. And the CDC has their own case definition. Back in May of 2020, Europe was seeing this. New York State had a health alert, and really everything culminated in May with this clinical syndrome. The case definition is you have to have a fever for at least a day, you have to have lab evidence of inflammation with blood markers, and really at least 2 organs are involved with no alternative diagnosis, but positive history by testing either molecular serology for prior COVID-19 infection or an exposure or a household contact, thinking back to the beginning of the pandemic when testing was difficult to make an epidemiological link. But if you look at this graph on the right, you just think about all the different systems that could be involved. They may have fever, body aches. They may have on their face a body rash. They may have red eyes, swollen lymph nodes in their neck. They may have neurological findings with headache, and they may have cardiac inflammation of the heart. They may have coronary artery aneurysms. Lungs may be involved, requiring oxygen, chest pain. Patients can have low blood counts. They may have kidney failure, may have gastrointestinal symptoms, really with severe abdominal pain. And all of these, there are many other different markers, but this is the syndrome that we're concerned with really in patients who really could have mild or no symptoms and present later on after their initial mild illness with this. So where we are in the US, there's been at least 5,217 confirmed cases that the CDC has kept track of, and 46 deaths. And you can see these numbers have, they're up from the original about a year ago, October 2020. And on the left graph, if you look at the right axis in black, that graph is showing the daily COVID cases. And then on the left y-axis in blue, it shows the daily MIS-C cases. So you can see that the MIS-C cases follow the peaks of COVID-19 acute infection. So this is exactly what we're looking for on alert and are starting to see here after our surge, patients that are presenting anywhere from 2 to 4 weeks or up to 6 weeks with this clinical syndrome. And the concerning thing that it is an acute illness, they are very sick, and they need to be hospitalized for treatment and diagnostics. So, another example of where children can be affected after COVID infection, a little bit different than the long COVID that we've been talking about. The median age is about 9 years, and most of the patients, almost 40%, are between 6 and 11, but it can be up to 21 by age definition. And there is a MIS-A, multi-system inflammatory syndrome in adults. But here's just kind of a graphic to describe from left to right what happens. Patients may have a SARS symptomatic or asymptomatic disease without a close contact. They'll then present with fever, and they can have either a Kawasaki-like disease where they have the fever with red eyes, rash, mucosal involvement, lymph nodes, similar to Kawasaki's disease, which our clinicians are very alert to here in Hawaii. Or they may have shock, which they may present with low blood pressure and need to be in the ICU. And the main concern that we have is that there's multi-organs involved. This whole system, they're in a hyperinflammatory state in terms of all of their labs. And the 2 big concerns we have is the heart. They may have function problems, so the heart is not able to pump blood to the rest of their body. And they may have coronary artery dilatations, which can lead to coronary aneurysm, which can be pretty deadly. So the main thing is that we have a diagnostic and treatment algorithm that we've alerted many of our clinicians in the clinical practices in the outpatient, the hospitals, and the emergency rooms. And the treatment is to decrease inflammation and try and allow recovery, monitoring of these cardiac patients. So really, this is another long-term follow-up that patients have. Once they're treated in the hospital, they have a long-term follow-up that we're still determining, following these kids up to a year to see what their body is really, how their body is affected by this hyperinflammatory process. So another thing to consider is what how has COVID affected children besides being acutely ill, besides having long COVID or post MISC? And really, this is just kind of a quick look at 6 different areas. Education, children we had school closures, we had distance learning. There are multiple social determinants of health that may have had difficulty with children attending classes, or children don't want to pay attention to the computer and be on the monitor. We have special ed children that need real one-on-one assistance. So that was another way children are affected. When we think about children, the development is from preschool, elementary school, intermediate school, high school. There's all types of socialization that happens in school or with their peers. And, this is something that really can create a difficulty in children, making friends, interacting with people, let alone maybe being fearful that they're going to get COVID if they go back to school or participate in activities. Besides interacting with their peers, they're not interacting with adults, with their teachers, with their coaches. And, that's another part of how COVID has affected children. We know physical activities were limited, sports, club sports, team sports were shut down. And so that's another way that our children didn't have increased activity. We know that there was an increase in the percentage of obesity reported recently. I know when I looked, earlier in the year was about 11%. The last report that one of our colleagues, Dr. Mayo Kuhiro, had talked about, the numbers are up to 14%. Kids aren't walking around, they're not walking to school. And then extracurricular activities, we know everyone's life has been changed with COVID, but that's specifically important. There's no Cub Scouts, Girl Scouts, or there's a whole different level to how activities occur now. And really the last point, and I know there was a very good seminar at this festival on mental health and isolation, and that's something that we need to think about. So, I think that there are, 3 areas, that children have been affected in COVID. And when we look at the numbers, my hope and the glimmer of hope that I see as we've had the eligibility of vaccines go down to 12 years is the next up and coming group, 5 to 11, looking forward to trying to prevent these severe diseases, these severe MISC and long COVID with vaccination moving forward. But even with this vaccination, we still need to consider all the other layers of masking, hand washing, staying home when we're sick. And I feel like all of those things can try and prevent our keiki from being affected by COVID in these ways. Thank you.
Thank you, Dr. Ching. Excellent presentation. You're tuned into the Hawaii Book and Music Festival, the long COVID panel on the wellness track. Long COVID is when we get COVID-19, but there are persistent symptoms that can be very troubling, very disabling, painful, and can last a long time. We first heard from Dr. Bennett Loui, Chief of Internal Medicine at Hawaii Pacific Health and head of the long COVID clinic. Dr. Ching just finished. She's a assistant professor of pediatrics at the School of Medicine and practices pediatric infectious disease at Kapiolani. Dr. Bennett finished up with a reminder that vaccination is probably the best way to prevent long COVID. And Dr. Ching, made the important point that COVID doesn't just affect our children when they're struck by the virus. It affects them socially, it can affect mental health. And she spoke of the really exciting development that we will very soon hear if the children 5 to 12 are now eligible for vaccines. That group is larger than the adult group who chooses not to vaccinate in this country. Our next speaker is Dr. Neal Palafox, who's not only a medical doctor, but also has a master's degree in public health. He's a professor of family medicine and community health at University of Hawai'i. And his career has really been dedicated to not just family medicine, but community health, social determinants of health, health disparities, and global health issues. Dr. Palafox, welcome.
Thank you very much, Dr. Zunin. And I'm really fortunate to be with a very expert panel here in all facets. And I too was a JABSOM, Johnny Burns School of Medicine graduate, went to UCLA for my residency. But I spent 10 years in the Marshall Islands following my residency, working with many of the health problems. So as Dr. Zunin said, I'm very attached to the Pacific Islander, Pacific health. So I'll be speaking on long COVID, and my lens is really translating some of what happens in the medical setting into the societal and specific populations in Hawaii. So why is this? So what I'll be doing is really briefly is talking about the emerging terms and definitions of long COVID, the societal impact, the uncertainty, and several speakers talked about that. The healthcare system's impact, particularly the healthcare providers' impact, and just learning about the diagnosis and treatment that Dr. Loui talked about, and it's not easy and it's new. And so how does that affect providers? And then some general questions for researchers and the community. So emerging terms. So as Dr. Loui mentioned, just so that the terms become more user-friendly, long COVID has been termed different things over time. It's been called long haulers COVID. It's been called chronic COVID, long COVID as we're using, and it's called PASC in many of the current settings, which is post-acute sequelae. So after the acute situation, what follows after the SARS-CoV-2 infection. And the PASC definition is further broken down depending on who researches it, but certainly it's usually 4 to 12 weeks beyond the acute infection. And then there's another phase that people are now breaking it down into, as you learn more, 12 weeks after the onset of the acute infection. But again, some of these are descriptive, some of these are research, but these terms will be fired at you in the general public, but they're essentially wanting to frame similar long COVID, the long COVID illness. So one of the things that, as was described, and to understand long COVID, and so the natural progression after symptoms is usually the PCR test, which tests for the, it's a molecular test, which tests for the genetic material of the virus. Usually after the symptoms occur, 4 weeks after, it sort of really goes away. So the PCR turns negative. And so what long COVID is things that happen after there's no detectable or very low detection rates of the PCR. There's no detectable genetic material, and the actual COVID virus is supposedly not active. And so what Dr. Loui was mentioning and what Dr. Ching was mentioning is this is what long COVID is. It's what happens in the months after this. And they both really presented an idea of what happens with, in the long term after this. But this is why it's defined this way. So, one of the things that presents an uncertainty is, and Dr. Zunin mentioned this, is that we're learning as we go and everything about this virus, whether it's, vaccinations and medications, use this, don't use this, how to test, how not to test. But one of the things that we can look at is the SARS-CoV-1 and MERS were both coronaviruses. One was an epidemic in 2002. The other one, MERS, was Middle East Respiratory Syndrome, 2012. Again, both MERS and SARS, but both of them had long-term effects. And I only bring this up to show you that we're, Dr. Loui and Dr. Ching were mentioning, 9 months out, 12 months out. These studies all showed, and it was studied, that there were effects 24 months out. And it was 2 years after the illness, 29.6% of the healthcare workers didn't return from, SARS, and there were a lot of, and this was actually quantified, but I don't want to go into the actual data itself, but 52% of SARS survivors had impairment at 24 months or 2 years after the illness. So again, we're on a curve of learning. We don't know what's going to happen, but it's to adjust to that. This has been a learning curve for the entire society, but certainly for the physicians and the scientists as well. And we're learning as we go, but it's being patient with it and adapting to change and what that means. So the multidisciplinary team care. So Dr. Loui spoke about this a little bit. And so as he mentioned, long COVID affects multiple systems, and it takes a wide range of experts to deal with it. And because it affects the pulmonary system, the blood system, the kidney system, the renal system, and certainly a lot of the behavioral neuropsychiatric. And primary care is where I sit. And if, there's a coordinating part of this. So in other words, it will take the health system some maturity to adapt to this, because you can notice that, Dr. Loui in his clinic and Dr. Ching in her clinic has to deal with, the COVID, long COVID, but a lot of it over time will grow, and it needs to end up in a multidisciplinary setting, and that system has to adjust, and all of the different providers and experts have to learn about what this is, what it isn't, how to make the diagnosis, and what their exact role is, so that we can take care of the patients really in a multidisciplinary team medical care setting. So I'm showing this because one of the things about COVID-19, this is Hawaii specific, this is data as of October 11th. Remember, Dr. Bennett and Dr. Ching mentioned that, there's certain risk factors that increase your possibility of long COVID. And one is if you're hospitalized, right? And so look at this graph, and this is state data right off the state data system. If you look at this, 4% of Pacific Islanders, which are Samoans, Tongans, and the Micronesians, make up 4% of Hawaii's population are Micronesians, but of that, they represent 20% or fivefold the hospitalizations from COVID. Native Hawaiians are overrepresented by 2% in hospitalizations, but the other population is Filipinos. They make up 16%, but have 22%. So what this means is that you're going to see a larger percentage of long COVID just by the fact that they have more hospitalizations, and they have also carry a lot more of the COVID-19 infections. These are the deaths, so it shows you the impact of COVID. So again, Pacific Islanders in the state of Hawaii, 4% of the population, but they're owning 20% of the deaths. 20% of this 815 are Pacific Islanders. 22% are Filipino, but they have 16% of the population. Actually, from a death standpoint, the Native Hawaiians are below their representation. So again, there's not an even distribution of hospitalizations, of COVID-19 infections. And also, it probably speaks to what Dr. Loui was saying in the obesity realm. Pacific Islanders, Native Hawaiians tend to be, in general, again, lots of reasons for it, heavier, a lot more chronic conditions, but it speaks to why we have to pay attention to the different populations and how they are hit, and what that would mean to our systems, our providers, in understanding how to work with this. And so this is, again, right off the Native Hawaiian Pacific Islander. I work with many COVID response teams, including the Native Pacific Islander. But again, this is a summary slide. The deaths, 20% are Pacific Islanders, and they're only 4% of the population. The COVID cases, 14% of all the COVID cases, but they're 4%, and Native Hawaiians, 25% of all the COVID, and 18% of the deaths. So again, understanding that it's not evenly distributed, but our systems have to adjust to that. So, some of the things that, questions for the community and so forth is, there's a scientific questions. What are the long-term effects of COVID on functional exercise capacity because it affects the lungs? Is there a role for antibiotic therapy? All these different questions, which are medical questions, prolonged prophylaxis, but also I think there's population level questions. How do we ensure that the most vulnerable populations receive adequate care? How are physicians trained for that? How is the system made competent for that? And I can say, directly that I've worked with COVID in these populations since COVID began. And in every phase of it, nobody knew how to deal with the Pacific Island populations. So they're under-vaccinated, under-tested, heavier, infection rates, heavier death rate, heavier hospitalization rates. Why is this? Part of it, I think, is the system's competency. What is the community, civil society, our role in general, not the medical role, to mitigate the impact of long COVID or past? And so these are just questions, and I just high-level view of these things, and that's what I wanted to present kind of a translation of what it means to the larger community. And that's my last slide. Thank you very much.
Dr. Palafox, are you able to take the slides down there? Thank you. Thank you. You've tuned into the Hawaii Book and Music Festival, the wellness track on long COVID. Long COVID, when people get COVID-19, but don't fully heal within 4 weeks. We heard from Dr. Loui, Bennett Loui, Chief of Internal Medicine at HPH, and Dr. Natasha Ching, Professor at Jefferson in pediatrics and at Kapiolani, pediatric infectious disease, and Dr. Neal Palafox, family medicine physician and professor of family and community health, talking to us about health disparities. Dr. Loui, in your slides initially, there was one, the bottom of the slide, kind of mused about the causes of long COVID, and we read articles where some will assert that it's actually damage from having had the virus. Others postulate that it's persistent virus, kind of chronically persistent virus. Others would favor kind of the chronic inflammatory disease or damage from inflammation, and then immune dysregulation. What's your feeling about the cause of long COVID?
Well, I think we're talking about long COVID. We're just defining it, and it probably involves a combination of all different processes. So there may be fevers and fatigue may be related to the immune system. Certainly inflammatory damage can affect your cardiac condition, and we see more heart rhythm problems and other cardiomyopathy, inflammation of the heart. That is, an inflammatory process. So there may, I think that it's, we're talking about a few different processes. I don't think there's one of those things that you listed that explains everything.
I guess, would you say though that to the extent that we can determine the cause of long COVID, that would also inform approach to treatment? Say if there's persistent virus versus post-inflammatory damage or persistent inflammation or immune dysregulation, seems like that might inform our approach.
Absolutely, yeah. And so we're just defining what long COVID is part of the issue. So I think we're settling in on some definitions now. I mean, the WHO just made their statement just maybe 2-3 weeks ago about what they think the worldwide consensus of what long COVID is. CDC made their statement a month or two ago about what they think. So first we have to talk about the same thing, and then we can sort of pick apart what is causing those conditions. But certainly, everything is being studied all at once. This is such a huge worldwide issue. There are researchers all over the world studying what conditions are happening, and then what could modulate it or improve recovery, and also how to prevent it. Such as the possibly vaccination. So we're doing research on all fronts all at once. As I mentioned, the NIH has this huge, $1 billion grant to research long COVID specifically, and that's going to be over the next few years. And we're going to learn a lot more.
Thank you. Dr. Ching spoke to us about pediatrics. He's a pediatric infectious disease specialist working on long COVID. At Manakai Omalama, at our clinic, we're getting so many questions from parents about whether or not they'll be able to vaccinate their children ages 5 to 12. What's the status of that? And if this pediatric population is vaccinated, how will that affect their risk of long COVID?
Well, right now we know that the FDA Advisory Committee is meeting on October 26th. And after that, the CDC's Advisory Committee is meeting November 2nd and 3rd. So I feel like we'll have more information from our regulators, but as a pediatrician, as a parent, and as a pediatric infectious disease, I'm very hopeful that we will have a whole nother group of children who are going to be protected from getting acute COVID and then getting any long COVID infection post symptoms, however long that may be for children, and really the rare MIS-C syndrome that can happen after even asymptomatic COVID infection. And besides preventing all three of those things, it's going to give a different flavor to how they can continue on with life, starting to, have sports be more open, not just, the safer sports, having their extracurricular activities, having, play dates where families are going to feel a little bit safer and another layer of protection. So I feel that many of those things are all going to benefit children and hopefully allow them to not feel, the weight of many of the restrictions that they've seen. It's children who have a year and a half, it's 2 grade levels that's been affected in school education. So I think that we want to make sure parents understand, the dose is 1/3 of the adult dose, at least for the 5 to 11 years. It's still the Pfizer vaccine is 2 doses, 3 weeks apart. And what we do know is that they showed that the children had the same amount or comparable protective antibody as the adolescents and young adults when they were studied with this standard Pfizer dose. So
Dr. Ching, we have a question that just came in relevant to the breakthrough cases of COVID. So now let's look at the older pediatric population, and let's say they were vaccinated early in January, February, and now are 6 months to 8 months or more out from their primary vaccination. Is that when people get COVID? And if you get COVID as a breakthrough, do you know in the pediatric population if the chances of long COVID are more or less or the same as people who have primary cases who have been unvaccinated?
Well, there's a lot of questions in that, but I'll speak to the pediatric patients that are of the age to be vaccinated who are sick. And so they are not vaccinated, but the rate of breakthrough cases, I feel is very low based on the more recent vaccination. So 12 to 15 really only started in May. And so what I feel is that there may have been a very few cases. I don't have all the data that's requested by the DOH, but in some of the instances I know of, they weren't fully vaccinated yet. They didn't have the 2 doses and 2 weeks after that 3rd dose.
But
I think more of the data for the breakthrough information is in the adults, truthfully. I'm sure someone is collecting that data in different pockets, but I don't have that specific data here. The most of the infected pediatric patients with severe disease are those who are unvaccinated.
Dr. Loui, are you able to speak to that? The kind of this question of risk of long COVID in breakthrough versus unvaccinated.
Well, that's a great question. Everyone is asking that when I go to long COVID meetings, and what is the relative risk? And just from that one report that I mentioned, prior vaccination does seem to reduce the incidence of long COVID. But we have to learn more. I would intuitively think that vaccinations would reduce would be less likely to lead to a COVID. I think also for the kids, Dr. Ching, not only were children vaccinated more recently, but their immune systems are much more tuned up. If a 12-year-old got vaccinated in May and a 70-year-old got vaccinated in May, I would predict that the 12-year-old would have a stronger persistent response.
Sure. Thank you. Thank you. We have just a few minutes left, and I'd like to give the last word to Dr. Palafox. Dr. Palafox spent 10 years in practicing in Micronesia and has had a long and highly regarded career in family medicine and community health, population health. One of the cries of injustice through the COVID pandemic has been the low rate of vaccination particularly in Africa, but relatively also initially in India, Russia, South America, it seems fairly clear that where the vaccinations are low and the cases are high, we're seeing so many cases of long COVID that are probably undiagnosed, and if diagnosed, not well treated. Can you speak to that?
So that's also a lot to unpackage, but I think vaccine hesitancy is defined as if the vaccines are available and can be deployed, people still don't go. So Africa is a little bit different than some of these other countries because sometimes it's availability or their ability to deploy. But I think your question is, in our communities that we know, and we see under treatment and under testing and under vaccination, is why is that? And the probably 2-second answer is kind of like Dr. Louis' answer is multidimensional, because it's not just health. A lot of people think it's just health or information or translation. It is actually deeply involved in the Pacific Islanders' perception of the system. Do they trust the system? Do they trust the government? How have they been treated in the past? Is there what they call cultural safety in the system? So in other words, if they go to HPH or Queens or My Clinic, do they feel safe there? Do we have somebody to translate? Do they have a face that looks like them? So a lot of these things, our systems in Hawaii do not have. It's not wanting to have it, but they're not present. And so therefore, the ability to access these things is difficult. And we often try to boil it down to us language, or they don't understand. It is a deep political, religious, cultural issue, and it all comes together, and you see what you have. So I know that's anyway. Thank you.
Dr. Palafox, if the governor or the head of the CDC or the head of the DOH came to you and said, Doug, you've been in the trenches for a long time. If there's one thing that we could get done, what would help the most?
I would say currently, like you mentioned, get more people vaccinated and educated, but it's a long process and they've been working on it for a while. So that's what I would say, but it's a
Thank you.
long
Thank
journey.
you. We'll have the closing comment by Roger Jelinek, the master of the Book and Music Festival. Roger.
Aloha, thank you very much. That was really fascinating, a little scary, and quite mysterious in some respects. My measure right now is that a lot of people are going to be interested in seeing this who were not here or could not come. And it will be available, and you can tell your Ohana, your networks, this on the Better Tomorrow Speaker Series YouTube channel. And then it will be rendered somewhat to highlights in a couple of weeks, and that will be available on our website for at least the next year. So you're now all immortal. And I thank you again very much. It was really an excellent panel, and you probably could have gone on another hour quite easily. Thank you very much. Aloha.
Thank you. Thank you, everyone.
Thank you so much.
Thank you.
Uh-huh.